Welcome back. Today, we dive into one of the most critical challenges in transthyretin amyloidosis, timely and accurate diagnosis of cardiac involvement, or ATTR-CM. The problem? Delayed diagnosis. A study found that 35% of patients with wild-type ATTR were initially misdiagnosed, often with hypertensive or hypertrophic cardiomyopathy, ischemic heart disease, heart failure with preserved ejection fraction, or even aortic stenosis. These delays contribute to disease progression and reduce treatment response. Now consider this. The valine 122 isoleucine mutation, most common in among African American populations, is found in 3.4% of African Americans, translating to roughly 2 million people at risk in the US alone. This underscores the need to diagnose ATTR-CM early, before irreversible damage occurs. Despite growing awareness, diagnosing cardiac amyloidosis remains difficult. Why? Because its symptoms often mimic more common conditions, like hypertensive heart disease, chronic kidney disease, hypertrophic cardiomyopathy, or aortic stenosis, and because many clinicians still believe effective therapies don't exist. But the reality is changing. Though AL amyloidosis is indeed rare, wild-type ATTR-CM is emerging as far more common than once believed. In fact, contemporary studies report that up to 10% to 16% of older adults with heart failure or aortic stenosis may actually have underlying ATTR wild-type cardiomyopathy. So when should we be suspicious? Start with patients over 60 presenting with left ventricular hypertrophy, specifically when the wall thickness exceeds 12 millimeters. Add red flags like heart failure with preserved ejection fraction, atrial fibrillation, pacemaker implantation, or bilateral carpal tunnel syndrome, CTS, and the suspicion should be high. Yes, carpal tunnel syndrome. In the wild-type ATTR-CM, bilateral CTS is a common clue. Among ATTR-VCM patients, CTS and peripheral neuropathy occur in 46% and 53% respectively. Another telltale sign? A declining blood pressure in patients previously treated for hypertension. It may be the disease unmasking itself. Importantly, ATTR-CM is also found in 14–16% of elderly patients undergoing transcatheter aortic valve replacement, TAVR, particularly those with low-flow, low-gradient aortic stenosis. So why does early diagnosis matter? Because the earlier we detect ATTR-CM, the better patients respond to disease-modifying therapies like tafamidis. Data show that patients in New York Heart Association Class Y and II benefit most, while advanced disease sees diminished returns. Sadly, diagnostic delays are common. A registry study spanning 17 years showed that in 42% of cases, the diagnosis was delayed by more than 4 years, with devastating impacts on quality of life and healthcare use. So how can clinicians stage and act sooner? Tools like the National Amyloidosis Center, NAC staging system can help. Stage 1, NT-proBNP less than or equal 3,000, an estimated glomerular filtration rate, eGFR, more than or equal 45. Stage 2, intermediate range. Stage 3, NT-proBNP more than 3,000 and eGFR less than 45. Targeting high-risk patients for routine biomarker screening, including NT-proBNP and troponins, can support earlier identification. Ultimately, early detection isn't just a clinical preference, it's a life-saving imperative. ATTR-CM is progressive. Tafamidis may slow or stabilize it, but it cannot reverse existing damage. So we must act before heart failure takes hold, before quality of life is lost. By recognizing red flags and adopting a structured diagnostic approach, we give patients the one thing they don't have: time. Early recognition saves lives. 1. Be alert to subtle symptoms and clinical overlaps. 2. Screen high-risk patients with cardiac imaging and biomarkers. 3. Diagnose early to preserve cardiac function. 4. Start treatment before New York Heart Association Class 3. In this segment, we focus on how cardiac imaging has been integrated into the current diagnostic recommendations for ATTR-CM, both in the European Union and the United States. Recent diagnostic algorithms published by leading cardiovascular societies, including the American Heart Association, AHA, the European Society of Cardiology, ESC, and most recently the American College of Cardiology, ACC, reflect a significant paradigm shift in how we evaluate cardiac amyloidosis. These updated guidelines emphasize two key goals. First, to help clinicians identify and confirm cardiac amyloidosis in a timely manner. Second, to clearly differentiate between the two major types: AL amyloidosis, typically due to a circulating monoclonal protein caused by a plasma cell disorder, and ATTR-CM, or transthyretin cardiac amyloidosis, which may be wild-type or hereditary. To support this, diagnostic algorithms recommend a stepwise approach that combines non-invasive imaging with monoclonal protein screening. Let's break this down. Monoclonal protein testing should include serum and urine protein electrophoresis, SPEP and UPEP, serum and urine immunofixation, IFE, and a serum-free light chain assay, SFLC. These tests are crucial for ruling out AL amyloidosis. Once that's done, we move on to imaging. The primary imaging tools in this process are echocardiography and cardiac magnetic resonance, CMR. Together with lab results, these help form a more accurate and efficient diagnosis. Here's a comparative look at the diagnostic flowcharts developed by the ESC, AHA, and ACC. They all highlight the importance of recognizing clinical red flags, as well as abnormal findings on ECG and echocardiography. Monoclonal protein screening is central, and where appropriate, bone scintigraphy using Perugini grading is performed. The 2023 ACC consensus makes two important notes. First, it allows concurrent ordering of cardiac scintigraphy and MP screening to save time. But interpretation of the scan should only be done if monoclonal protein screening is negative. Second, if bone scintigraphy is negative or inconclusive, yet clinical suspicion remains high, a biopsy is advised to avoid false negatives. These detailed, harmonized algorithms are helping us identify ATTR-CM earlier, differentiate it from ALCM or other cardiomyopathies, and begin treatment while it can still make the greatest impact. Now we'll walk through the diagnostic approach to cardiac amyloidosis, with a particular focus on ATTR-CM, as recommended by the European Society of Cardiology, or ESC. This approach was formally outlined in the ESC's 2021 position statement on cardiac amyloidosis. It offers a structured, stepwise diagnostic framework to support early recognition, targeted investigations, and subtype confirmation of amyloid transthyretin cardiomyopathy. Although there are points of alignment with guidance from the American Heart Association, AHA, and the American College of Cardiology, ACC, the diagnostic workflow we'll be following here is based primarily on the ESC pathway to reflect European clinical standards and practices. Let's begin by looking at the overall diagnostic algorithm. This algorithm integrates clinical evaluation, electrocardiography, ECG, echocardiography, bone scintigraphy using technetium-labeled radiotracers, and serum and urine tests for monoclonal protein screening. The aim is to improve diagnostic accuracy and sensitivity through this multimodal approach, allowing clinicians to make a timely diagnosis, differentiate between AL and ATTR subtypes, and guide appropriate staging and prognostic decisions. Let's move into step 1, the identification of clinical red flags. This is the essential starting point for evaluating suspected cardiac amyloidosis, and it's emphasized in all three major guidelines: ESC, AHA, and ACC. In patients who present with heart failure symptoms or left ventricular wall thickening, and when other common conditions like hypertrophic cardiomyopathy or aortic stenosis are ruled out, we must be alert to specific signs and clues that point to cardiac amyloidosis. These red flags include a range of symptoms across multiple systems, such as visual disturbances, carpal tunnel syndrome, autonomic dysfunction, unexplained gastrointestinal symptoms, and neuropathy. From an ECG standpoint, a key feature to watch for is low QRS voltage, typically defined as a QRS amplitude less than or equal 5 mm in all peripheral leads. This is a frequent finding in cardiac amyloidosis and should always prompt further evaluation. Echocardiography remains one of the cornerstones of non-invasive assessment. Red flags on echo include inferolateral wall thickness more than or equal 14 mm, which had an AUC of 0.73 in studies. Average basal longitudinal strain more than or equal -8%, with an AUC of 0.76. Relative apical sparing ratio more than 1, though less specific, still contributes diagnostic value. AUC of 0.53 and a 95% confidence interval ranging from 0.52 to 0.55. These features, when observed together, substantially increase suspicion and are critical parts of the ESC 2021 diagnostic framework for ATTR-CM. Step 2. Initial diagnostic testing, monoclonal protein screening, and bone scintigraphy. Once red flags are recognized, the ESC recommends monoclonal protein screening and bone scintigraphy as the next step. This is a dual-pronged diagnostic approach that uses blood and urine tests for monoclonal proteins and bone scintigraphy, typically using technetium-labeled radiotracers such as 99-MTC-PYP or 99-MTC-DPD. This combination allows for both sensitive detection of amyloid deposits and early differentiation between AL and ATTR amyloidosis. Steps 3 and 4, diagnostic stratification and subtype classification. Now comes the point where interpretation begins to diverge depending on the monoclonal protein, MP, test results and the Perugini bone scan score. Let's start with the ESC approach. ESC diagnostic pathway. In MP-negative patients, a Perugini score of 0 suggests that ATTR-CM is unlikely, and typically no further testing is necessary. A score of 1 warrants an endomyocardial biopsy because early or low-grade ATTR-CM could still be present. A score of 2 or 3 is diagnostic for ATTR-CM. The next step here is to perform genetic testing to determine if it is hereditary, HATTR, or wild-type, WTATTR. In MP-positive patients with a Perugini score of 0, the ESC advises cardiac MRI, CMR. If CMR is positive or inconclusive, biopsy is required. If CMR is negative, ATTR-CM can be excluded. And importantly, if a patient has typical CMR findings for cardiac amyloidosis and a positive extracardiac biopsy for ATR, this combination is considered sufficient to confirm the diagnosis. Scintigraphy is no longer necessary in such cases. AHA and ACC pathways. Now let's compare this to the AHA and ACC guidelines. The AHA and ACC recommend that in the presence of a positive MP test, clinicians should proceed directly to tissue biopsy. Scintigraphy is not required in these cases. For MP-negative patients, their recommendations mirror the ESC. A Perugini score of 0 or 1 with suggestive findings, biopsy. A score of 2 or 3 confirms ATTR-CM, requires TTR gene testing to identify subtype. MGUS complication. There's one more important consideration, MGUS, monoclonal gammopathy of undetermined significance. It's seen in over 20% of patients with wild-type ATTR-CM, and it can complicate interpretation. In these cases, a hematologist's assessment is essential. If uncertainty remains, endomyocardial biopsy is still required to accurately determine the amyloid subtype. While these consensus algorithms guide the integration of imaging and serological data for accurate diagnosis of ATTR-CM and its subtypes, it is crucial that clinicians remain aware of the diagnostic capabilities and limitations of each imaging modality. Step 5. Staging and prognostication using cardiac biomarkers. The final step of the ESC diagnostic algorithm focuses on staging and prognosis using cardiac biomarkers. Once the diagnosis has been confirmed and the ATR subtype is determined, staging helps to quantify disease severity, predict clinical outcomes, guide treatment decisions, and support ongoing monitoring. Biomarkers used in this process include NT-proBNP, BNP, and troponins. These markers reflect myocardial stress and injury and offer non-invasive insight into disease burden and response to therapy. The ESC and the UK National Amyloidosis Centre, NAC, both endorse the use of the following staging model. Stage 1, NT-proBNP less than or equal 3000 NGL and eGFR more than or equal 45 ml/min/1.73 m2. Stage 2, either NT-proBNP more than 3000 or eGFR less than 45. Stage 3, NT-proBNP more than 3000 and eGFR less than 45. This staging framework was validated by Gilmore et al. 2018. An alternative Mayo Clinic model uses NT-proBNP and troponin T instead of eGFR. Recap of the 5-step ESC diagnostic framework. Let's briefly review. Step 1, identify red flags on clinical exam, ECG and echo. Step 2, conduct monoclonal protein testing and bone scintigraphy. Steps 3 and 4, interpret based on Perugini scores and MP status, confirm ATTR-CM and determine subtype. Step 5, use cardiac biomarkers to stage disease severity and guide prognosis. This structured, evidence-based algorithm improves our ability to diagnose ATTR-CM early, classify it accurately, and manage it effectively. In our next lessons, we'll discuss each step in detail. See you there.